Hi, I think we can start now. Hello and good afternoon, everybody. Thank you for joining us at this webinar on managing with cancer during COVID-19. My name is Kiran Sivaraj. I'm a medical oncologist and the co-founder of the Oncoshot Cancer Collaborative Platform. This webinar is organized by the Singapore Society of Oncology. The Singapore Society of Oncology is a professional medical organization which is consists of Singapore healthcare professionals who treat and manage cancer patients. And this event was organized with the goal of sharing important advisories to patients, caregivers, and members of the public. We aim to address questions that you may have during the Q&A session with our panel speakers. I have with me three esteemed specialists whom I would like to introduce. Dr. Leong is an infectious disease expert who may be a very familiar face to those of you who have watched his recent interview on radio and the internet. Dr. Leong was previously a senior consultant in the public sector and is notably an experienced and well-respected figure in the medical community, having supported the country with its expertise during the SARS epidemic and H1N1 pandemic. Dr. Leong will be taking us through a short but important general advisory for cancer patients and caregivers. Hello, Dr. Leong. Maybe you could give us a nice wave there. Hi. And following Dr. Leong's presentation, we will start on a Q&A session where oncologist Dr. Choo Su Pin and Dr. Joline Lim will be addressing some of the important questions that were raised by many of you at the point of registration. Now, Dr. Choo is the current president of the Singapore Society of Oncology and previously the head of the gastrointestinal oncology unit of the Department of Medical Oncology at the National Cancer Centre, Singapore. She's a recognized global expert in liver and pancreatic biliary cancers. She currently practices at the Curie Oncology Clinic here in Singapore. Hello, Dr. Choo. And we also have with us Dr. Lim, who is Dr. Joline Lim, who is a consultant medical oncologist based in the National University Cancer Insitute, Singapore. Dr. Joline Lim has subspecialty interest in breast cancer and is also deeply involved in biomarker research. She's also an investigator in multiple clinical trials and will offer her perspectives from her experience of COVID-19 within the public healthcare sector. Hi, Dr. Lim. So do bear in mind that while we aim to address this topic broadly, especially given the significant number of attendees from overseas, a lot of the questions may be, a lot of the points that we bring up may be defined within the Singapore context. Yeah, so that's just something to keep in mind. So without any further delay, I would now like to hand over the screen to Dr. Leong for his short talk.
Hi, I'm going to get the slides here like this. I'm going to screen share. There you are. Share. Yes, excellent. Every time when we go through these technical things, I really worry that we get a glitch. But thankfully, everything has been very fine. I'm very, very honored to actually have the Singapore Society of Oncology as well as Oncoshot give me an opportunity to share with you and speak to you all. For people who are actually cancer patients, I'm going to say, first of all, you are not a cancer patient, you are a cancer survivor. So for that, I salute you. I'm extremely proud of you. It's just very unfortunate that during this time we have COVID-19 and it kind of makes things difficult and the way we treat and manage. Okay, I'm going to touch on a few things. Number one, what's the risk for COVID-19 and when you have actually cancer, what's the risk of COVID-19? And then what's the concept of this Trojan Horse, where people can actually infect others? And the next thing we'll talk about is how does transmission occur? Because if you understand how transmission occurs, in turn we can actually put in barriers and how to prevent and how it works. So when you actually have the understanding on the prevention, then the common sense will come in and then we can effectively protect the cancer survivors back at home. And I'm going to touch very, very briefly on treatment that's available for COVID-19. Now, this is a plot which is taken out from BBC. The good thing about COVID-19 now is all the newspapers and the media will come out beautiful graphics. And this is one from BBC. It tells you one thing, that the most important reason for survival is not because you have a smart doctor, it's just simply because youth. If you're young, your chances are you don't need hospitalization, you tend not to die. So that helps tremendously. Just simply being younger, the odds are much better. So among the panelists down here, unfortunately, I'm the one that's heading towards the death risk higher. The rest are much, much younger than me. So that's youth will help you, age will help you. Then if you look at the other conditions, heart problems is another big problem. 10.5%, the risk of dying is much higher. The same again, diabetes or the existing lung diseases is not so good. Now, cancer ranks at about 5.6%. So it's slightly higher than the rest, than the no health condition, 5.6%, but it is much, much lower than heart diseases. Now, if you really look at the numbers overall, the risk is actually quite small. Because of the 100 persons there are that has infection, 80% will do well without any leak or anything. Of the 20% here, another 30 to 40% may actually die. And of this, only a small proportion will have pre-existing cardiovascular diseases, etc. So your actual risk is not very high. So in all likelihood, even though the risk is slightly higher, I expect most people to come out of COVID-19 without much problems. Overwhelmingly, most people are fine. Now, then if you look at it, at the very top, you will have people who will die. That's the smallest number. Then the bigger number will be people who actually have severe disease, and of course, the mild or asymptomatic. Now, up until February, up until the end of March, we felt that the mild and asymptomatic weren't very, very big. Or perhaps there were quite a bit of mild, but the asymptomatic group was actually very, very small. But things have started changing. Okay, so if we look back at the fatal and the severe form, these group of people, they will have fever, cough, they're feeling unwell. And one thing I didn't mention in the slide is the lack of the smelling sensation, a nose smear. If you cannot smell something, the chance of this being COVID-19 is actually quite high. At least 50% of them would have, lack of smell sensation. So if you find that, think about whether you're COVID-19. Then for the mild asymptomatic, these are people with little or no symptoms at all. So they may have a little bit of cough, and then they'll say, hey, but it's a cough which I have every day, and they're fine. Or they have a bit of runny nose, or in one patient that was featured in the Straits Times, the only thing he lost was the sense of smell. I do have patients under my care now with COVID-19 who have no symptoms at all. So these are cases, and they may just come to you. And the reason for that, for highlighting that is, if a person says he's well, he is not sick, he has no cough, it doesn't mean that he doesn't carry COVID-19. So he may still be asymptomatic, no symptoms, and still pass the infection to you. Now, the significance is that he becomes a Trojan horse. You accept the gift of the person coming in, but in fact, he actually has a virus inside him. And then with that, this Trojan horse can inevitably infect other people. It is with this understanding the government went into a circuit breaker mode. You just stay away from everyone so that there's no chance of you meeting a Trojan horse. If you don't meet a Trojan horse, then you won't get infected. So remember, this virus is very special. It's very sneaky. It uses people, and it's a Trojan. The person is a Trojan horse, and it can transmit even though he has no symptoms. Going by symptoms alone is not good enough for COVID-19. Now, you can imagine this group of people on your right of your screen. These are your visitors who will want to come and visit you, who are sleeping and resting in bed. Okay, so the problem, some of them may actually be asymptomatic COVID infections, and then when they come and visit you, you can actually fall sick and acquire the infection. And the best thing to do, and the most important thing to do, is to not visit. When you don't visit, you don't come in close proximity. No close proximity means physical barrier. with a physical barrier of physical distancing, then you would be protected altogether. Why? Because in order for the transmission to occur, you have to come within close distance. And for all intent and purposes, for COVID-19, we assume it to be 2 meters. If you see the person and he's 2 meters away, then you're fine. The chance of transmission will be very, very low. So if you have to see the person, keep the person 2 meters apart and you'll be fine. Come within 2 meters, the flying droplets can actually land on you and you can fall sick. Now, you also realize that in COVID-19, some of the singing activities will allow you to project your voice much loudly. Then some of the droplets may actually spread quite easily. Okay, so what you really want to do is to maintain at least 2 meters. If I can, I want to have a door in between so that these people and the patient, they do not meet. Now, if I have to meet, then the outdoor environment is better. Out in the open, there's a lot of sharing of the air will come out and it will circulate. The risk of transmission is practically nothing. If you have to do it indoor, I want to do it in an indoor, non-air conditioned situation. But if I were to do it indoor and it's air conditioned, it's a bad idea because the virus loves the cold and loves the dry air. And then the air would then hold on to the virus a bit longer. It'll stay on the environment a bit longer. So if I have to meet someone, outdoor is best. If not, indoor in a open area with the windows and doors all wide open to let the air through. That will help tremendously. Now, the other way which we can do is actually to use masks. Masks actually help in preventing a transmission. So if these people were to wear a mask, the mask will prevent the transmission of the virus across to you. Okay. Then, in addition, when you wear a mask, you will prevent yourself from getting sick. So 2 masks, one worn by the visitor, the other one by yourself, will prevent transmission. And you don't think of it as unilateral, but think of it as combinational. So if this mask is, say, 99% effective, then you have your own mask as another 99% effective. All in all, your chances of protection is extremely good. Some people may also have realized that the cloth mask that's issued by the government or the handmade cloth masks are not as good as the surgical mask. That's true. Let's assume that the cloth mask is 50% effective. You wear it on this side for your visitors, and that 50% is actually for yourself. Together, you have a 4-fold reduction in the transmission of virus. Okay, now should I wear a surgical mask or should I wear an N95 mask? If you look at my face, I've got an acne spot here. This came about because of all the N95 masks that I was wearing, and it's so irritating to my face. When it's irritating, there's a tendency to touch my face and adjust it, and in turn, you actually break infection control. So, but what about efficacy? I can hear people shouting to me now, but N95 is better. This is a study to actually look at N95 versus surgical mask or no mask. When you don't wear a mask in prevention of influenza, no mask puts you at risk. When you put a surgical mask and N95 mask, the efficacy is about the same. So if I have a choice to, I'd rather wear a surgical mask, so it's more comfortable than N95 mask. Now, this is another mask study to show about influenza, for influenza prevention, surgical mask and N95. So N95 may have a slight advantage, but the advantage is very little that can be taken away simply because you touch your face, touch your eyes, or adjust your mask, and then that's not effective. And for N95 to be truly effective, you need to be mask fitted. That means different people, different shapes of faces needs different masks. Use a different, and sometimes getting the wrong mask just makes it difficult. So my choice to you, especially if you're not well, if you're a cancer survivor, I will wear a surgical mask and not the N95 mask. Now, the other thing that happened is actually through handshaking, through touching objects, etc. When you shake hands, you can transmit. But the objects too, they'll come over, someone may touch something, and the virus may be on the table. In turn, when you touch the table, the infection can go on. So the best thing to do is stay away from people and don't let other people come close. My mom, for example, is a cancer survivor, and I can tell you at this point in time, no one's visiting them at all. They have, my father is with them, they have 2 helpers, but no one's visiting them except my wife and myself, and even then, we have a very short visit with a mask. So as long as you have a physical distance away from anyone, you are really, really quite fine. And after handshaking, if you really do come in contact or kind of object, wash your hands with water and soap is fine, or alcohol rubs are perfectly great as well. So again, just now we're going to the summary of the preventive measures. The best thing is avoid, don't visit. Or if you have to visit, have a social, physical distancing so that no one can come close. Outdoors are better than indoors, and indoors are better than air conditioning. The minimum distance is 2 meters, and try to keep visitors to a minimum. Household members. Household members, when you interact with other people in the public, you can bring the virus back into the house. So which means you should not, the people who are living in the same house should have minimal interactions with others at the same time. Masks do help. The surgical N95 for the common man in the street, there's really no big difference. The healthcare workers need N95 because in some situations, they need the extra protection. I prefer the surgical mask. I think it's much cheaper and the prices have come down. And lastly, all of us can have a healthy dose of common sense. Wash your hands often. Your face is sacred. Eat healthy food. Avoid raw food. And eggs, for example, I love eggs, but the raw eggs can actually carry a germ and bacteria and can mess up your treatment thereafter. That's the end of my slides. And oh, right, treatment. These are some of the treatments that have come up in the internet, and you might read about it in the news. The answer is that they don't seem to work very, very well. We don't have a good answer. In fact, all these drugs carry some risk one way or another. So the current treatment is not to start treatment on any of these drugs, but if you are deemed to be high risk and you are getting worse, we'll start treatment on one of these drugs or put you on trial on a special case-by-case basis. This depends very much on the doctor who's looking after you and the severity of your illness. It will take another 3 to 4 months before we have the trials of these results available. Then we'll know what drug works and what drugs don't. Okay, be very careful of what the news media reports. Some of them will have a lot of hype saying that it works very well, but in truth, we don't think so. So most doctors think they are not very effective. Okay, that comes to the end of my slides. I'm going to hand over the time to Dr. Hoe Nam.
Thanks, Dr. Leong. So that was very, very helpful. I think it really brought home the point that the entire concept is that there might be a large proportion of our population who may be mildly asymptomatic, and I think that's the main thing that we need to keep in mind as well. And all these barriers to transmission, such as the wearing of masks and avoiding contact, social distancing, keeping away of more than 2 meters, is actually essential in our risk of transmission and infection. Now, so today we have received an overwhelming number of questions from the point of event registration. In fact, we have had more than 500 registrants initially and more than 100 submitted questions. So we hope to have your understanding that while we will aim to address key areas of concern, very specific issues in relation to an cancer condition not be easily discussed. We will do our best to address some of the unaddressed questions with a resource page at the end of the event. However, detailed questions specific to your particular condition and situation will always be best addressed by a treating oncologist who knows you best. All right, so without any delay, let me just bring about Dr. Choo and Dr. Joline into the Q&A session as well. Let me start by asking a question. Maybe Dr. Choo, you can take this. Now, this is a bit of a recap of what may have already been discussed by Dr. Leong, but basically, are cancer patients and survivors at a higher risk of getting COVID? And importantly, do cancer patients who get COVID do worse? Yeah.
Okay, thanks. Thanks, Yuren. As Dr. Leong has alluded to, based on at least a Chinese study, cancer patients, because if you're a cancer patient and you're on treatment, especially if you're on chemotherapy, which is a cytotoxic, it may reduce your immune system, or is likely to reduce your immune system, and you're more prone to any kind of infection, including COVID. And if you look at, and even without any treatment, even if you just have cancer and you're not on active treatment, generally speaking, your immune system is usually lowered anyway, and you're just more prone to complications if you have infection. So the short answer is that yes, you are at higher risk. That's why we are we are trying to emphasize the fact that you really need to protect yourself, and should avoid unnecessary visits to hospital if possible, and protect yourself from anybody who may be a potential COVID positive person.
Thanks.
What's the second question, Yuren?
Second point was actually, do cancer patients do worse when they get?
Yeah, I think Hoe Nam answered that in the chart in his slides, that cancer patients do worse together with patients who have chronic diseases, because cancer is a comorbid chronic disease as well.
Maybe Dr. Joline, you can answer this next question. How can cancer patients protect themselves from COVID? I mean, that we kind of know. Whether there's anything in addition that you might propose. And a very common question that we've also had, importantly, is how can cancer patients build up their immune system, avoid getting the infection?
I think at this point of time, the most important is like what Hoe Nam did mention. It is really about preventing contact and decreasing exposure. So I think even your oncologists or your hospital doctors will be working very hard to see whether or not they can decrease your exposure by looking at alternative options for your treatment if you're on active treatment. And if you're on surveillance at this point of time, you may actually receive a call from your own oncologist or the team in the hospital or the clinic to basically maybe reschedule some of your appointments when it comes to surveillance scans or when it comes to follow-up appointments, because it is very important for us to decrease the chance of exposure, because we know that if you get exposed and if you do contract the disease, you are likely to do worse than another otherwise healthy person. I think in terms of immunity and how we build that up, I don't think that there is a very easy answer to that. I think most of us advocate for healthy living, exercise, making sure that your nutrition is adequate, whether or not there are supplementation that would definitely make you stronger than others. I don't think we have very, very strong evidence one way or another. But I think being able to maintain a good, healthy lifestyle is probably what's most important now, especially during this period of lockdown when most of us are really just staying at home. Yeah, that's where I come from.
Okay, yeah, thank you for that. Dr. Choo, maybe you could answer this question. So one of the things is many patients have encountered that their treatment or their appointments may be deferred. General question here is, should cancer treatment be deferred because of COVID? And maybe importantly, if they're going to be deferred, which ones do you feel are really acceptable at this time for us to delay or postpone?
I think our group, cancer patients who are cancer survivors and patients in three groups in terms of priority. Those who start with the ones that are not urgent. Not urgent would be patients who already finished their treatment, who are in remission, who just have follow-up visits to do a scan or to do some blood tests and all that. I think those are really not urgent, and those can be deferred. Okay. Then there's the group where some treatment will be, there's treatment, but the treatment is having treatment now versus treatment in a few weeks' time or pushing treatment a bit later will probably not make much difference to the cancer. These patients can also have their treatment delayed. Then there are the patients who need treatment, because if we don't have the treatment now, their cancer condition will deteriorate, and it won't be good. Okay, so those are the ones who are a bit more urgent or need treatment soon, and we need to control the cancer, otherwise the patient will suffer. But you can't answer this question without talking to your oncologist, because every cancer is different. Even within cancer types, some cancers are more aggressive than others, and also depends on what treatment you're on. And this has to be discussed with your primary oncologist. In terms of what we're doing as oncologists is we're actively, I think, and Joline will talk about public sector. In our private clinics, we have been cutting down our patient list and telling patients don't come if you don't need to come. If we can do home phlebotomy, we can do home procedures, we do everything at home. Patients who can have oral chemo instead of injection chemo, because injection chemo cannot be given at home, you have to go to a clinic for that. Then we will switch to oral chemotherapy where possible, without making sure that it's not detrimental to the cancer itself, in terms of the cancer treatment. We also basically try and deliver drugs to patients if they don't need to come. The patients are very stable and we just need to repeat another cycle of chemotherapy. Then we do teleconsults, and then we will deliver the drugs to patients, and then we do home phlebotomy, we review the blood test, we do a teleconsult, then we send the drugs over.
Dr. Joline, maybe you could share a bit of insight into some of the measures that may be used in your own center.
Yeah, so I think at our center, we have implemented quite a few changes, and these changes are still ongoing because I think the COVID-19 situation is rapidly evolving. And every time we see a new surge and all that, we have to increase our measures to ensure that our patients are safe from exposure. So right from the beginning, I think a lot of us have called up our patients who are long-term surveillance scans, who have otherwise been treated and are no longer on active treatment, to try and basically delay their appointments. The hospital has been very prompt, working with the pharmacists to try and do home delivery at no extra cost to the patients. And we try and call up our patients. I think in general, patients who are currently on treatment, if we cannot stop the treatment, we have to continue. But we do try and streamline the visits so that we don't have to make the patient come down multiple times. In terms of the chemo itself, we may actually start to look at regimes or treatment that would be shorter in terms of duration, again, to decrease the exposure. If there are options of doing subcutaneous injection formulations instead of intravenous treatments, then we will consider that. And of course, oral treatments instead of IV treatment, like Su Pin has mentioned. I think that telemedicine is also something that we have been working towards. There are certain patients who have been long-term stable, especially hematology patients on our side, where we just do teleconsults and we will actually send the medicines to the patients. In terms of whether or not patients can actually get their blood tests and scans done at home, blood test, we used to have a community nursing arm that will be able to do that, but because of the resources required to manage COVID-19 patients in the hospitals, unfortunately at our center, the community nursing arm has been put on hold so that we can concentrate our resources to help our patients who currently need help in the hospital. However, there are third-party phlebotomy options out there, and I think if you really wanted to, you could speak to your oncologist to consider whether or not there are these third-party phlebotomy services that you may be able to employ and help to take blood and ferry the blood to and fro the hospitals. But this is not routine for us in the public sector.
Thank you. So thanks for sharing a lot about what's been happening in the public sector rather. Maybe just to segue a little bit and also to cover a very interesting question that we had. Now, we know that in Singapore, dengue is actually quite endemic over here. And we had a question from a patient who said that she was on active chemotherapy for her breast cancer. And in fact, in her area, it is a dengue hotspot. Now, how does she now protect herself from dengue plus COVID. And I think this question is also relevant because we have many participants from the region where dengue is also endemic. So Dr. Leong, maybe you can help us answer this question.
I think that's a great question. I think we've got a double whammy. We do have a lot of dengue cases ongoing now. At the same time, we have COVID-19. In order to overcome the dengue and the mosquito issue, you have to understand how the transmission occurs. Number one, it must be through a mosquito bite. If you don't get bitten by a mosquito, you're fine. Then number two, if you know that it has been a mosquito bite, then you need to know what are the biting habits. It likes to bite in the day. It's a day biter. So, and particularly between 10 a.m. to 4 p.m. So if you get bitten in the night, hooray, it is not a dengue mosquito or the Aedes mosquito, but if you get bitten in the day, it might be a dengue mosquito. And then if you are fast enough to catch it, you can actually look for the bands, the white bands on the legs. But 90% of the people who get bitten by Aedes mosquito have no recollection. So you may still get the dengue and not know about this. Number three, be aware that the most common place of bite would actually be still around somewhere in the house or somewhere in the home. I know you're obsessive your own home, but I can't say the same for your neighbor. So the mosquito might be just next door to you and flies over. So think not of the individual responsibility, but the group responsibility for the whole neighborhood. Okay, so how then can you prevent? Stay indoors. Stay indoors in the day. Number two, if you want to, you can actually use a mosquito repellent. A DEET mosquito repellent of at least 15% might be helpful. It's also called, the brand is called OFF, OFF. WHO has other recommendations as well. You might have heard of using some, the scent, I can't remember offhand, citronella. You may use our citronella. I think citronella helps, but I don't have solid evidence, I don't have solid science to back it up like DEET. So you may use a combination of citronella together with DEET, or there's another called piperacillin, which is another compound which WHO has granted approval for use. So for this is about all that you can do. Make an effort to exterminate any breeding areas, and the chance of getting dengue should come down thereafter.
Thank you, Dr. Leong. So that was a very detailed insight into what we can do to prevent getting a dengue infection as well, which is, a double whammy we really want to avoid in this period of time. So we have an interesting question here. It's an unplanned question, but I thought that maybe we can address this. Dr. Choo, maybe you might want to take this up. So the question was really, how do we differentiate between patients who have febrile neutropenia while on chemo and patients who are having a fever from COVID-19? And what kind of investigations would you do, and how do you manage that?
Okay, I think this question needs to be answered together with Dr. Leong. I think we've faced this before in the wards. Basically, the problem with cancer, and if you're on cancer treatment, obviously, if you're on chemotherapy, your counts may drop and become neutropenic. In COVID infection, correct, Dr. Leong, that can happen as well. In fact, lymphopenia is a sign of COVID infection, and that makes the diagnosis even more difficult.
Yes.
Especially in the early days when we're testing for COVID. Dr. Leong can discuss about the testing for whether you're COVID positive and how accurate that is, especially in the early days of infection. So that's a problem. That's why, but we still have to try and work out all potential causes, including COVID, including just regular infection due to bacteremia and all that. And sometimes we know our patients, we know the timing of the chemo, we know roughly when the counts would drop, how many days after the chemotherapy. And if we know that patient has a predilection for a certain type of infection, for example, I tend to see patients who have a lot of biliary sort of infection around the bowel system, right? And then there are some signs in blood tests that point towards that, which are more suggestive of a biliary infection rather than a COVID infection. Furthermore, COVID infection tends to have the respiratory symptoms, which Dr. Leong has talked about. But then again, we also have patients who have pneumonia, and it may mimic a COVID infection. So it's a challenge for us, but it's not impossible for us to differentiate. And maybe Dr. Leong, you can comment about the COVID testing part. Yeah.
COVID testing, this is a very sneaky virus. Very quickly, we evolved, the mainstay is actually through PCR. It is not through a blood test. So you put a swab into the back of the nose, and at the same time, I often like to do a throat swab at the same time and put it into sampling. But your accuracy of it, depending on where you do it, as in which country and which assay you use, your sensitivity or your pickup chance could be anything from 70% right to 90%. Even then, most centers do not have a 100% pickup rate. The reason is that the virus, upon entering your system, will quickly travel downwards. So we have had many patients who were negative on the 5th or 6th swab, even though we're very sure it was. But eventually we diagnosed it through a blood test or a scope down into the lungs. So only on the 6th or 7th test will it turn out positive. So even though you're negative on a swab, you may not be negative for COVID. You need to look at the whole clinical picture and decide. The second issue is people have heard of the rapid test and the blood test. It's called the serology test. They also call it the IgM, IgG. It's a great test, easy to take, but it has severe limitations. About 90% of them will turn positive only after 14 days. So when you're having fever, when you're feeling unwell, and everyone's upset and worried, the serology test doesn't work. So it only works when you're much better. After the war is over, they say, oh, you actually had COVID the other time. So unfortunately, we don't have a good way of diagnosing it. As what Dr. Choo says, how do I decide? I have to look at the blood test, I have to look at the chest x-ray. This is on top of the detailed history, looking at the symptoms, and then to complement it together with testing, and whether there's any links with anyone who had COVID recently. All these 5 different reasons adding together, then we make a calculated risk whether the person has COVID or not. So not easy, quite challenging.
Yeah, thank you for sharing about this investigative modalities. I think it sheds a little more of insight into how complex it actually is to actually make a diagnosis, particularly for patients who have other comorbidities or conditions. Yeah, Dr. Joline, maybe you can take the next question, because we've talked about how patients may present with symptoms that are suggestive of complications from treatment, but which may also be COVID-19. Now, if a patient were to be infected with COVID-19, I think one of the concerns amongst our cancer patient population is, what is the risk to them in the short term and long term? How much do we know about the implications of a COVID-19 infection within our cancer patient population?
I think the short answer is that we don't know enough, unfortunately. I think it is true that things have really grown exponentially over the last 3 months. We have had small studies that have been published to describe patients who have gotten COVID-19, and amongst these patients, how many of them were cancer patients, how many of them had cardiovascular disease, which is I think what Hoe Nam shared just now in terms of the incidence. But I think that at this point of time, none of us really know what the long-term implications are, because this disease is just so new at this point of time. It's barely been 6 months since it has surfaced. In terms of short-term implications, I think that we do have a little bit of information from small studies, especially from China, that suggests that patients with cancer are at higher risk, and that risk can be 3 to 5 times higher than a general population, number one. The other point, of course, is that not only are our patients at higher risk, and when they do get a disease, they can have a more severe disease, meaning that there is a higher chance that they develop symptoms compared to patients who are otherwise healthy. If they develop symptoms, there is possibly a higher chance that they will have more symptoms and more severe symptoms that may require some form of medical intervention. So I think it is important that our patients are very vigilant when it comes to symptoms. The government has put out an app for how you can check for your symptoms, and that's something, an easy tool that they may be able to use to check their symptoms. And if they have symptoms, the most important thing is to actually be able to contact their oncologist or to go to the hospital early. A lot of us have this fear of, if it's just a little bit of a fever, or if I just feel a little bit unwell, maybe I shouldn't go to the hospital, because if I go to the hospital or I see a doctor, I may end up mixing with people who may actually have the disease. But I think it is important to acknowledge amongst our patients, especially the patients who are on active treatment, that our patients are at high risk, and that if there are symptoms, we should not take them lightly. And if needed to, please approach your oncologist or go to the hospital or the clinic that you actually receive treatment at, so that the doctor can assess for you and then make the decision for you as to whether or not this is COVID, or whether you need further investigations like swabs.
Okay, thanks, Joline. Dr. Leong, quite a few questions that maybe some things that you could help address. Now, one interesting question that we had in the Q&A was, if I had a COVID-19 infection and I recovered from it, is it possible for me to get COVID-19 again? Have there been cases like that we've already seen, or are we considered cured once we have recovered from a COVID-19 episode?
We believe that once you have COVID infection, you only have it once and only once. What happens is your blood will actually develop antibodies, ammunition against the virus. If the virus tries to come on again, it will actually kill it. Now, then why did people keep asking about this question, does it come back? The reason is many people shed the virus in their nose and in their feces for many, many weeks. So, for example, I've discharged myself, I'm well, I've COVID before, I've recovered. But when I go out to the community, I develop a cough again, maybe because it was a cold, there was some reflux. So the doctor comes and sees me, does the swab, and he finds a virus. It is not a new virus that came on, but the residual virus from the previous infection, they're still shedding. That means the virus is there, not causing trouble in you, but it's still excreting small amounts. And we do know it sheds for weeks, okay, 4 weeks to 5 weeks, it has been reported. If you look at the feces, it can last for even months. So the lesson to learn is that you test in Singapore, you see many patients that are kept in hospital, though they are well. They are not there because they have respiratory symptoms or they're sick, but because we don't want them to go out to community and spread the infection. So we are keeping them where they will have no risk to other people. Now, if you really don't like someone and you have had COVID before, remember your shit is really toxic.
Dr. Leong, just to clarify, so actually, what is the time frame for which such patients who have an infection need to actually keep themselves isolated at home, if they're actually quite mild symptoms? Because I think that's quite important, so that they don't come out and potentially expose people with the viruses that they're shedding as well.
Absolutely good question. From the data that's coming out from the publications and the experience on the ground, it can easily shed for 3 weeks. And average, it sheds for 3 weeks. So if I had COVID, child in Singapore, you'll be locked down until you're negative for 2 occasions. If you're a foreigner and overseas, then how long would I keep myself in the house without contact? 4 weeks. Okay, 4 weeks. And even then, when I do use the toilet, I will make sure I close the lid and flush. Because if I leave the lid open, I'll be sharing my goodness out in the toilet with everyone.
Right. Thank you for all that goodness. Let me just get back to the oncologists in our team. And so all three of us here are medical oncologists, but there are some questions on what happens with patients on radiation treatment as well as surgery. maybe we could take turns to kind of just address it in a very broad sense based on clinical experience with your colleagues. Dr. Choo, one of the questions was, so this is a patient on definitive treatment, and I think it's for head and neck cancer, where he's going through daily chemo and radiation together. And that means coming back to the hospital for radiation therapy every day. Now, what is the experience that you're having in the private sector, and how do you all actually advise, or how are the radiation oncologists actually advising or guiding their patients through this frequent visit process?
For patients on definitive treatment like that, you really have no choice because the radiation machines cannot go to your house. Some radiation oncologists have been changing the way they dose their radiation. So in terms, there may be a shorter course but higher doses of radiation versus a traditional very long course dragged out over 2 months or whatever, okay, of radiation. So that's one way. This you have to discuss with radiation oncologists whether this is an option for your kind of cancer. It may not be an option for your cancer. It may be an option for your cancer. From the oncologist's point of view, we are just for definitive chemo radiation, we're just the sort of an adjunctive treatment. We also have to worry about neutropenia. That's when the immune system is suppressed. So we often have to do intermittent blood checks to check on the white cell count and so on. And we try and do those blood tests at your home rather than coming over, or you do it very quickly. The patient's coming over for radiation, we try and do it in a very short period of time. So patients don't sit around waiting in the clinic or in the hospital. I'd like to highlight to patients and relatives, if you're coming to hospital, really try and minimize the number of people that accompany you. If you can come alone, come alone. If you need someone to accompany you, try and stick to one person accompany you, unless you're wheelchair bound or you need an interpreter, then that can be a little bit tricky. If you're coming to a hospital, always wear a mask. And there's one thing about seeing a doctor, I always notice patients, the minute they walk into the clinic room, they pull down their mask and start talking to us. You know, the mask is to protect you. It's also to protect the people in the clinic so that we don't spread any viruses to other patients as well. Keep your mask on, unless the doctor needs to examine your mouth or something and ask you to remove the mask. And always remember hand hygiene. Someone asked about doorknobs and all that. The doorknobs and all that also apply to doorknobs in clinics, though we are now a bit more obsessive with sterilizing our door handles and wiping our surfaces and wiping our examination couches and all that. Even our chemo chairs are wiped down all the time after every single patient. You still have to be careful and protect yourself. And when you go home, if they have finished your definitive chemo RT, just like we doctors, when we go home, we don't sit down in our office clothes in the house. Some of us change before we go home, and then we shower. We always throw the clothes, for us, because we're high risk, we always throw the clothes, some of us throw our clothes separately and wash them separately. You don't have to do that. But really, if you're going out, especially if you've gone to a hospital or clinic, when you go home and your family, and you've reached home, wash your hands, then shower, change before you sit down onto your bed or something.
Thanks, Dr. Choo. Dr. Joline, maybe you could take the other question about, the context of surgery.
Right.
There are situations that surgeries can be delayed, especially surgeries for cancer, right? In this particular condition. What are you seeing that's happening? How are the surgeons from your own prioritizing? How are they adjusting before bringing patients for cancer-related surgery?
I think that we are still making adjustments. This has changed over the course of the last month because of the number of cases that have rapidly been rising in our country. We need to be very aware that any patient who goes for cancer surgery, there is always a risk of post-surgical complications. And if you have a high-risk surgery like bowel surgery, biliary tract surgery, these surgeries are considered high risk than, for example, a breast surgery or a lumpectomy, just to remove the lump in the breast. And the higher your risk of surgery, the more cautious your surgeon is likely to be, because they would be more worried that if you develop a post-surgical complication, that you may end up in the ICU. And we know that, you know, the government has been telling us this day in, day out, the ICU beds are stretched at this point of time. And we don't want to be put you in a position where, you know, you may risk not getting an ICU bed. So I think before any patient is actually being treated, the good thing is that we do have a multidisciplinary tumor board. We would discuss all our patients together in the presence of surgeons, medical oncologists, radiation oncologists, and even our diagnostic radiology colleagues who look at the scans for us. And together we make a collective decision as to what would be least risky to our patients. Would it be to do surgery first if the surgery is lower risk, or if maybe it is a small cancer, and after surgery, the patient doesn't actually need any other treatment, because every modality of treatment, be it surgery, chemotherapy, radiation, they all have risks involved. Coming back every day for radiation is a risk of exposure. Getting chemotherapy, neutropenia, being immunosuppressed is a risk. And surgery, like we have mentioned, because post-surgical complication is a risk. So we weigh that day in and day out, trying to figure out which is the lowest risk possible for each patient. I think if the risk of surgery and post-surgical complications is high, there is always an option of considering what we call neoadjuvant treatment, which is basically giving chemotherapy, radiation, or even hormonal therapy for some cancers that are actually sensitive to hormone treatment, to basically try and sort of buy time till the surgery may be safer. And also, of course, to possibly shrink the cancer to make the surgery an easier surgery. And I think that at this point of time, a lot of us are considering that as options. And if you have certain concerns as a patient, do speak to not just your oncologist, but your surgeons, and discuss about these options that may be available to you.
Thank you, Joline. Just a short question from a very conscientious patient. So this person was asking, what do I do if I'm on oral medication? Do I take 2 months or extra supply of my oral medicines? And would that be considered hoarding? And how would that potentially just impact, a hospital or a clinic? Joline, maybe you see a lot of patients with breast cancer, a lot of patients on oral hormonal therapy. So maybe you could just share your experience with that.
I think that if patients are on treatment and have been stable, in general, I personally prefer that they continue the treatment if they're and not risk coming to the hospital. This differs because some patients may have just been started on their oral treatment, and we do need to monitor them a little bit more closely in the initial phase. But if they've been on the same treatment for 3 years, and we're just seeing them every 3 to 6 months, I may stretch it out to 6 months instead of seeing them at the 3-month mark. It's also important to realize that endocrine therapy like hormonal treatment doesn't really suppress the immune system. So I think it's generally quite safe to continue taking this treatment during this period of time. Because there are some patients who take endocrine therapy or hormone tablets together with other treatments, and these are the patients who we need to be more cautious about. I think it's important to emphasize that it doesn't mean that because you're on an oral tablet, your tablet is less toxic than someone who is on intravenous treatment, because there are oral treatments that can cause similar side effects with intravenous treatments, and we still need to monitor these patients closely, especially when we first commence the treatment. So I think if you are a stable patient, there's a very good chance that your oncologist will have already called you and offered to provide you with a higher amount of drug to try and tide you through this period. In general, at least in our institution, we provide up to 3 months of supply. And I think we have been quite comfortable with that. At 3-month time point, we then review it again and decide whether or not we need to see you at that point of time, or if the COVID situation worsens, we may then give you a call, make sure you're okay, and then even possibly consider extending that further. I think we have been very fortunate in our country. We haven't really seen a big problem in terms of inadequate medications. That may change, and I think it is encouraging to see that patients themselves are also very conscious of this and trying to sort of help the community on a whole in terms of preserving our resources.
Thank you, Joline. Yeah, thank you. That's really true. I mean, I've seen a lot of patients who have been very civic-minded, community-minded in terms of the questions that they're asking as well. And we've not been able to share a lot of that because it's a lot of their opinions at the point of registration. But certainly, that's a very positive thing that we see. So I'd just like to ask the panelists whether there's any last thoughts that you might want to raise before I just go on a summary of some of the probably the key points and take-home messages that we want to raise at this point. Dr. Leong is good. Dr. Choo?
I think Kieran, you're going to share the resources. There are a lot of resources online from various organizations, including European Medical Oncology Society and so on, to help answer some of the questions that you guys have asked. And I think Kieran will share that. I think at the end of the day, if you're really not sure what your situation is, my bottom line is you really have to speak to your oncologist to sort yourself out. Yeah.
Yeah, I think it's the same on our side. I think in the public sector, there is an added challenge because we deal with many more patients. And the other challenge that we have been dealing with also is the fact that we have had to undergo some team segregation. Some of us have been sent to different hospitals, and that has caused a little bit of unease for some of our patients because they're not used to seeing somebody else. And that doctor-patient relationship between an oncologist and a patient is very important in the patient's journey. But I'd just like to reassure the patients who may be dialing in that even if you are not seen by your regular oncologist, before that oncologist would have left for being sent to another hospital, there would have been a proper handover. And we work as a team. So even if I can't see you because I'm posted to another hospital, the oncologist who's seeing you is aware. And whenever there's any problems, we talk to each other all the time. So please be reassured that it's a team effort taking care of you, and that we do not compromise your care as far as possible, even during this period of time, because we know it's important for you.
Thank you, Joline. So let me just bring up the slides that I would like to share. Right. So I think there are some key take-home messages from Dr. Leong's talk, as well as the many questions that were raised today during our session. And for me, this is probably the big thing that I would hope that our patient and caregiver community brings back home. The first thing is always, as much as possible, to reduce the chance of exposure and getting infection. And that means staying at home, wearing a mask, and practicing social distancing, keeping yourself away from people in public for at least 2 meters or further if you have to leave your homes. The second thing is managing cancer during the period of COVID-19 is a very complex situation that we are all in. And we're all learning about how to manage this better. And the situation is also changing on a week-to-day basis. The priority has to be that at the minimum that we try to reduce the risk of being infection. And the main thing to understand is why we are all doing all this cutting down of visits as much as possible. Is really we want to minimize the immediate short-term risk that patients would have because of COVID-19 infection. And that's actually a very key thing for us to remember. And the last thing, of course, is, all of us have very specific situations with management of our own cancers. And many of these cannot be answered in a setting like this, where we've tried to address very broad principles and concepts. And we need to understand that given the complexity of our cancer care, it's always going to be your oncologist who's going to be best placed to address the balance between the decision for treatment and whether you're going to come back and what kind of risk you're going to be exposed to when you come for your visits. It's always important to stay in contact with your physician, because they know you best, and to kind of work out a treatment plan with them for this period and beyond. And I think most of our patients will be in good hands during this COVID period, and we really want to take care of them and do our best for them as well. So just to go back on what Dr. Choo may have also raised earlier, many questions were not answered because they were very, very specific. But what we are trying to do as a group is to actually build some resources for the community of patients and caregivers, where you can actually come back and view this entire webinar, as well as some links to very good information and pages where you can keep track of what's happening, where when there's new information, you can also follow up with them. And I think these resources will be shared with our community of people who have attended this webinar over the coming days to weeks. If there are questions that you want to reach out to us or doctors here, please feel free to email us as well, and we'll try to get that answered even post-event. So we hope to bring more such events for you where relevant over the coming weeks to months. But hopefully we can weather this storm and it gets resolved sooner rather than later. So with that, I would like to say thank you to all our speakers. Thank you, Dr. Leong, thank you, Dr. Choo, and thank you, Dr. Lim.
Thank you.
And thank you to the more than 300 people who have been watching us over the last 1 hour. So take care, everybody. Have a good day ahead.
I need to join another WebEx. I'll see you. Bye-bye.
Bye-bye.